Good evening and welcome to another episode of the print virus Decode. I am Mohana Basu, special correspondent at ThePrint. And every day at 6 p.m., we come to you with a panel of experts to answer all of your questions. We are addressing the topic of reducing uptake in booster doses, and you can find a story done by my colleague, Abantika Ghosh, on the print website on this. Just a while back, we heard from the Union Health Secretary, Rajesh Bhushan, at the press briefing. He said that as many as 35 lakh healthcare workers became eligible for the precaution dose or the third dose of the COVID vaccine, of which 63% have already received it. Now, also, some 33 lakh frontline workers are now eligible for the precaution dose as of 20th January, that is today. And of this, 58% have already gotten it. And 48 lakh people above the age of 60 who became eligible for the precaution dose. And of them, 39% have already received it. So, according to the drive has been quite successful. So, is it now time for the booster program to open up to immunocompromised patients below the age of 60? And what role are boosters playing in other countries? These are some of the these are some of the questions that we will tackle through this episode. On the panel today, we have with us Sujata Rao, former Union Health Secretary. Along with that, we're actually waiting for Dr. Swapneil Parikh, a physician and researcher based out of Mumbai, to join us. He'll be with us shortly. We also have Abantika Ghosh, who has been tracking the pandemic for the print. Thank you for joining us. To our viewers, please do send in your questions, and I'll take up as many as I can through this show. Now, before we go to the audience questions, Ms. Rao, I'd like to start with you. You have been part of the ministry. So, how do you perceive the health ministry and the ICMR's role in the current pandemic in updating guidelines in response to the emerging global scientific data through the pandemic? I mean, do you think we could have done any better at turning scientific knowledge into policy?
One limitation that we have in response to the managing COVID pandemic has been that it's completely new. There is a certain novelty about this virus, and there's very little of scientific knowledge around in the world. So everyone is literally learning by doing and by waiting for more data to come up, more experience to be gained. So really, that's a very big challenge for a government, because as you know, every policy is based on what scientific evidence has already been gathered, analyzed, and on that a policy is made. So it's a reactive situation. Policy can never be prospective. I can never assume that another virus will come up of this kind of variant, and therefore I should be taking this kind of a policy and craft it. So in policy making, that's one serious limitation that the COVID pandemic has really put a challenge, to policymakers. That said, and therefore I have my full empathies or sympathies for my colleagues working in the Ministry of Health and ICMR in trying to manage, looking at all the data that is emerging both within India and outside India, in trying to figure out what needs to be done. But having said that, because it's such a challenge, I would have expected other, compared to other diseases or other more well-known infections, that there would be a much more collaborative framework within which policymaking would be made. Many more institutions, academic institutions, researchers, and particularly those who differ with government policy as such would be taken in, so that you hear both the viewpoints, and then the policy can be much more resilient and more robust. There's much more investment, that calls for investment that has to be made in research. For example, today, the newspapers carried a headline saying that 5 institutions of INCOSOG had to be shut down for doing genomic sequencing because of lack of funds. Now, that's not a good, sign for a situation when we're in the midst of a third wave. So this causes concern in the public eye, saying why is funding not being given? Or another news item that says that out of the 100 crores promised for genomic sequencing, and for research in COVID, only 15% of it has been released by government. That ought not to have been the case again. So I think, somewhere India's policy requires a much more scientific rigor and a much more of scientific basis and much more of investment in science is certainly required. And I would like to end by making a couple of illustrations to illustrate what I mean by that. For example, ICMR middle of December said there's no need for a booster because we ought to focus much more on completing 2 vaccinations for the entire eligible population. I also believe in that. I do think, because as you've seen, when you give 2 jabs, the persons who have got that vaccination have been protected from getting hospitalization or mortality. So that's a good policy, when there's a shortage of vaccines, you prioritize. But then later on, the Prime Minister contradicted that in December, immediately within 10 days, saying, no, there will be a booster. So what is the scientific evidence that is being used or has emerged within that gap of a few days that made policy change? That the public should know then. Similarly, the ICMR said, DG said, all the government policy today is 9 months gap after the second shot for a booster. Whereas most science abroad seems to suggest that the waning starts off after 4 months or so. And so they're recommending 6 months gap. And that is what the scientists also in our country have been asking for, 6 months. And today there's a newspaper thing again where AIG, a Hyderabad-based hospital, research shows that after 4 months, the immunogenicity, reduces and wanes. So therefore, waiting for 9 months, that means 5 months more, without adequate immunity within you could make you vulnerable to this Omicron. So this is what I mean by getting on-time real data by using many more institutions, being totally open and transparent. I mean, I would like to see much more openness. Supposing I'm critical of a policy, I should be the most welcome person there because I'm going to tell you, look, this is not it. And you can then get both sides of the coin and make a better policy. So it's in that context, I feel that, when these kind of sense of confusion or doubt emerges from a policy head like a ministry or an ICMR, it leaves the citizen a little confused, and that's not a good sign for handling pandemics.
Right, right. Thank you so much for that. And in fact, I think even Abantika will agree that we did have a lot of back and forth, where we would seeing, I would write something from the research perspective, and then Abantika would find something else out from, the health ministry. And there were a lot of gaps in how the response came. I see that Dr. Parikh has joined us now. So, I'll come to you with a question. From the perspective of healthcare workers, do you see colleagues who are reluctant to take the third shot that we are calling the precaution shot?
Hi, thank you so much for having me on. I think it's important to contextualize, what we're talking about here. We're talking about a homologous boost, that has come perhaps too late. That came after the third wave was well underway, that was offered after about 20 to 40% of health workers had just been infected. So a lot of people, whether I talk about my colleagues working in hospitals, in clinics, in laboratories, about 20 to 40%, maybe more, already got infected in the wave. So if you ask them now that, do you want to take the dose right after you've already just been infected? Of course, there's going to be hesitancy because it didn't arrive when they needed it. When we talk about this booster dose, we have to understand that we talk about severe disease, the probability that you have severe disease. It depends on the risk of infection and the risk of having severe disease if infected. So with 2 vaccine doses, the protection against the risk of infection, risk of severe disease, if infected, is pretty robust. But if the risk of infection has increased drastically because of a new variant, which it did, then the overall risk of having severe disease can go up. but it may mainly be because of the risk of infection increasing, not so much the risk of severe disease if infected. So I think that's something that wasn't really conveyed properly, that, that your risk of severe disease can go up if your risk of infection goes up. And then I think, as was just discussed, I was listening in, the messaging was very poor. The message of flip-flops in the messaging, and even at the same time, there was a difference in messaging from different parts of the government. So on one side, it was said, you don't really need this, there's no evidence. And on the other end, the message that was going on was, it's a precaution dose. What does that mean? Just, it's a booster, it's a third dose. So I think when you put things like that in people's mind, like, precaution dose, do I really need this? Whereas the messaging in other countries has been that you're a healthcare worker, you're highly exposed, you need this not just for yourself, but also if your risk of infection goes down, your risk of passing it on to your patients goes down. So the messaging, was very important. I think that's something that we didn't have. We didn't have enough time, right? Because we started rolling it out after the third wave was well underway, when a lot of healthcare workers had already been infected. And then I think the critical thing that comes up is that it's a homologous boost when it didn't have to be. So when I say homologous boost, I mean we're offering the same vaccine that was taken as the first and second dose. And it didn't have to be, because, we had Covovax, we had the Covovax vaccine. There was a clinical trial, cough boost clinical trial conducted in the UK that clearly showed that the Novavax candidate was superior as a third dose than Covishield or, an inactivated vaccine. I think healthcare workers, aren't they can assess information, they can assess the evidence. And I think we know that, yeah, sure, a homologous boost is better than no boost. But when you see that this vaccine that is being produced in India, that we've stockpiled, that we have tremendous capacity for, it's a great vaccine, more immunogenic, has a higher efficacy, had a better side effect profile, when it's being shipped abroad in the hundreds of millions or tens of millions of doses, and our health workers, the vulnerable populations in India, can't access it, at that point, it may not so much be just hesitancy of taking the boost, but it's just, why are you not letting me take the one that's, the best one? And maybe if I wait for some time, I will get the best one. And if you've just been infected already, then I would say that people are going to say, okay, fine, I'll just wait. I've just been infected. I anyway have to wait for 3 months. So I think there's a lot of issues with messaging, issues with a lack of choice, issues with starting too late, and I think most importantly the fact that a large percentage of health workers did get infected before the third doses could be rolled out.
Right. That's the point about homologous vaccines. We did, when the Prime Minister announced the booster program, we did expect, the other two vaccines to sort of come into the picture, but that did not happen. Abantika, do you think maybe a lot of people are actually waiting this out, to hoping that India will approve mixing vaccines, and now that we actually have two more, and is that why this number sort of went down?
So I think a couple of things. Firstly, like both our panelists mentioned, I want to add to that as late as 23rd of November, Dr. Balram Bhargava he's on record saying that there is no evidence that booster shots are needed. And the announcement from the Prime Minister came on 25th of December. That's the kind of flip-flop that we are talking about here. That is a problem. B, again, like Dr. Parikh mentioned, a lot of healthcare workers are already positive, so they are ruled out for the next 3 months. So that gap will always be there. Also, I want to emphasize one thing. The numbers that we were given today about precaution dose uptake, those are till 20th of January. And remember, this is a rolling figure, right? Because 21st of January, some more people will get eligible. 22nd. So it's not like it's now 63% or 58% for frontline workers, and it will get better because more and more people will become eligible. So this is a rolling number. I want to emphasize that. Now, I was talking to some doctors when I was doing that story about precaution dose uptake, low uptake. Some of the things I think that doctors are pointing out is that, we have so many times in so many different fora talked about Omicron being mild. People have really sort of bought into that. And then we see the way we have moved is first we said one dose is enough. That's why we increased the dose gap. Then we said, no, get the second dose. So now what it has come to is 6.5 crore people are overdue for their second dose. And now the booster doses have been, the precaution doses, if you want to call it that, have been rolled out at a time when cases are at all-time high. People, not all-time, but nearing the all-time high. People are scared to go into hospitals and medical facilities thinking I may just catch the virus there, so I'll wait it out. And then they are thinking, oh, this is a mild virus. I don't need this dose because the first 2 doses will save me. So I think the historical sort of gaps in communication are now all adding up with the booster doses, the precaution dose uptake.
Right. That's actually, a very interesting point because we have over the time seen how, of course, this is a developing, pandemic. We have learned things a little late. We've learned something and then unlearned it and then learned it again, and that has been the course of this entire pandemic. But that is why we still have so many questions. I'll move to some audience questions now. Anand Gopalan Kidambi from he's asking. Scientists are learning from are learning COVID-19 from patients. It seems that the world population has become rats for scientists. So this is basically about the confusion of why vaccines or drugs get rolled out and why we see approvals come after that. Ms. Rao, would you like to address this?
Well, I'm not a technical person, and I think Swapneil would be a better person to answer that. But I would like to only say what I feel, that, you do learn from the patients. And particularly when it's a new virus and you don't have a treatment protocol already done, tried, tested, proven, like I know if I get diarrhea, what I should take and what works, because for years and years, people have followed that. But here we don't have the luxury of that kind of knowledge, accruing to us for treating this particular infection. In fact, though it's a virus, it's so different from H1N1. It is so different from the other viruses that we have faced in the last 10 years. So, they're learning that, well, first it was felt that remdesivir is very, effective. Then they said, no, it is effective only under certain conditions. Then, WHO came up saying it's not effective at all. So they are learning from trial and error and from treating different patients. But today, 2 years later, we ought to be much more confident about what really works under certain conditions. And I think there's much more confidence in our doctors also. That's my personal reading. And I think Swapneil should be able to confirm or reject or deny that. But I do think today doctors know much, much more than what it was the case around this time last year. So I think, what is important for India is to do much more of a scientific inquiry, looking at evidence from our own patients and putting and documenting all that, because this is so critical for us to understand the way virus is playing out on us. Each one has a different genetic response to a particular viral outbreak. And we need to understand the Indian genetic response to this virus and build our own systems of the treatment protocols and so on. What has been, I'd like to conclude, is that, most patients today or people are picking up what drugs or what treatment lines we use by looking at TV programs. That should not be the source. The source should be the government. I mean, there should be a Fauci type, whether Fauci is good or not. I'm not getting into that argument. I'm just saying there ought to be an authoritative voice, whether it is ICMR, whether it is Dr. Guleria, or whoever it may be, the government should decide. And they should come up and say, sorry, CT scans cannot be used for diagnostic purposes, period. Something like that. But you cannot have these TV programs bringing in all kinds of experts from all over the country. And if you listen very carefully, sometimes there's a lot of contradiction between each, because each one has their own experience of no, two lawyers don't agree, two doctors don't agree, two mechanics don't agree, So that cannot be the source of information. So I really think that government should have very clear protocols and very clear treatment lines. We did it in HIV, treating HIV, for example, and that sort of clarity has to be there, where people can say, I want this because this is from an authentic source.
Right. Dr. Parikh, if you will, pitch in a little bit about from a layman's perspective, how would you explain this entire process of, a drug being discovered and then it going through trials and then eventually, the guidelines sort of forming based on the experiences?
I'll start with a quote by Dr. William Osler. He who studies medicine without books sails an uncharted sea, but he who studies medicine without patience does not go to sea at all. And of course, he, she, they, it could be anyone, just reading out Osler's quote. So, we always learn from our patients. I think most of my learning occurred at the bedside. It was from patients. And it's something I'm very grateful for. I would like to believe I didn't experiment on anyone. I certainly hope I didn't make anyone feel like I was experimenting on them. But the reality is we do learn from our patients. In a situation where we are posed with scientific questions, and a lot of scientific questions about diagnostics, therapeutics, everything about COVID-19 was so new. There were certain guiding principles, but everything was so new. And I'll come to certain paradigm shifts also. There's some questions that could not be answered at a certain point of time of the pandemic. But everything was so new that we had to put systems of inquiry into place. And the only way we could do that is with the cooperation and informed consent of patients. Far from viewing them as, laboratory rats, I view them as heroes. I view people who come forward and say that, please use my experience for the benefit of humanity. And this isn't just about patients themselves. Think about someone who's a parent and brings their child forward for a clinical trial in a vaccine. They understand that there's some risk there. But what they are actually saying is that I want to take this risk so that humanity can benefit. And we do this all the time. We have firefighters who will run into a burning building when everyone else is running the other way. We have health workers who will run towards a pandemic when everyone else is trying to work from home. So, our society is built, humanity is built on trying to serve others. And I think it's very empowering. It's a very empowering way to look at it that, when everyone felt so helpless, like, there's nothing I can do, this virus is going to get me, that in fact, patients who are afflicted by this disease could contribute so much to where we are today. Everything we've learned about this has been from, part of it has been laboratory experiments, in vitro experiments, but so much of it has been from patients, from clinical trials. The best evidence has come from there. So right. I view them as heroes more than laboratory rats, but that's just me. Coming to certain paradigm shifts, like I think the remdesivir story is an interesting one because, so for the benefit of the viewers, COVID-19, the illness, I'm talking about earlier on, before vaccines, when was occurring in a basically immunologically naive population that had not experienced the virus or the vaccines. There were two distinct phases. There was a viremic phase where the virus was replicating, reaching a high viral load in the person, and then there was a phase of immune pathology where the immune response to the virus itself could cause damage to the tissues. So very early on in the pandemic, we just could not use remdesivir. Remdesivir is an antiviral. It needs to be used in the viremic phase. But right. People were presenting late. Their symptoms were kicking around day 5, day 6. And then they were getting tested. Tests were taking a long time to return a result. And you were essentially starting a treatment that's meant to work against the virus in a phase that's the phase of immune pathology, where the immune system has kicked in.
It's like, the entire population as well as is working with the healthcare system to sort of bring forth and to take forward the scientific knowledge on this disease so that, we can just get better and better at managing it. And, I'm sorry I interrupted you there, but I would want to take forward the discussion to, something else that came up at the health briefing today. Abantika, there was a question about the subject expert committee recommending the approval of the market approval of Covaxin and Covishield. So I just wanted to understand from you, what is the difference between the two approvals, and basically what is it that will change for the public?
So in a non-pandemic situation, when we would probably not even have EUAs, but in a non-pandemic situation, it would basically mean that you can go out, buy yourself whichever vaccine of the ones available in the country, and take a shot. But this is a pandemic situation. A, this is just a recommendation. B, the government is perfectly within its rights to now say that even though this is full market approval, we will not let you sell outside because still our public health needs have still not been met. We will need to sort of, continue with the vaccination. So we need the vaccines for ourselves. So it is perfectly possible that even if the recommendation is accepted, it's not accepted yet. Even if it is accepted, this thing of going through COVID and getting your vaccines through COVID might still continue. But in other circumstances, a full market approval would mean that they are allowed to retail.
Right. They did say at the briefing that this will come with certain restrictions and all, which is going to be decided whenever that comes. Ms. Rao, coming back to you, since you have worked with the ministry for 20 years, why did the National Center for Disease Control, which should have been at the forefront in this epidemic, sort of just fall out of action?
No, it's just the perception that you have that it's out of action and is not doing anything. You have to remember that NCDC is a completely subordinate institution of the Ministry of Health. It comes under the DGHS, which is itself only the technical arm reporting to the Secretary of Health. So NCDC, unlike US CDC, it's not autonomous or independent. And it's not possible for the director NCDC to go out to the public and give an interview and or clarify questions or give press briefings or anything like that. It's for the ministry to put them up in the front and say, instead of Mr. Love Agarwal, it's going to be our director NCDC who is going to take questions from the audience, So it is up to the ministry, which needs to say this is our institution, it's our technical arm, and they are the ones who are doing the research, and they are the ones who are going to clarify. So, NCDC has to get everything cleared by the ministry. And I want to say that this because almost 20% of total genomic sequencing that is being done by the INCOSOC 38 institutions is being done by NCDC. So it's not as if NCDC's contribution is negligible, but then you don't hear them because they're the silent workers at the back.
Right. That's actually quite good to hear.
The reform has to be made. I don't believe this is a satisfactory situation. I do believe that this is a moment when a strong policy decision should be taken to make this and the DCGI completely autonomous so that they really are our watchdogs for disease. And DCGI, of course, has a different mandate of drugs and vaccine approvals, but both should be out of the arm of the Ministry of Health.
Right, absolutely. As a journalist, I would want to hear a lot more from some of these institutions, which unfortunately have been a little bit quiet throughout the pandemic. Dr. Parikh, coming back to you, we're in the last 5 minutes of the show. So just quickly, do you think it's time to open up boosters for immunocompromised patients who are under 60, the cancer patients and people whose immune response may not have been as great with two doses?
I think we're very, very late to this game. So the case for additional doses in individuals who won't respond to the primary series has been very, very strong for a very, very long time. I would say probably over a year. So we should have been doing this a long, long time ago. Certainly now, if not then, certainly now. I think there's no question about that. Yes, we should.
Okay. Coming back to you, Ms. Rao, you did talk a lot about how how the communication has been from the health ministry. So, how do you think it can be improved, and do you think it has improved from say 2020, when it just started out to now to the latest briefing, maybe?
I do think that, over the last 2 years, certainly after wave two, the communication has certainly improved. It was very, very inadequate before that, I feel. But now it has improved. We hear much more of the government advisories coming in. But then they will still have a long way to go. As Swapneil so beautifully put it, what does precautionary dose mean? I mean, it's, your after second dose, they say the immunity levels have gone down, antibodies have gone down by 30 to 30%. So this another dose will just pick it up to another 70. So you're boosting your immunity. What is the precautionary? So it gives a wrong message and it creates and this is very important. Words you're using gives you the image in the mind, and your response system to a particular policy will depend on the words that are used and the messages you're trying to give. So I think there's a much more sophistication required. Maybe they should take the help of professional organizations in this.
All right, Abantika, last question to you. From the briefing today, was there any point that jumped out? Something that you think the viewers should know?
What jumped out again is that 2 years into the pandemic, 1 year into vaccinations, we still don't know how many breakthrough infections, what percentage of people who are dying are fully vaccinated, what percentage is not vaccinated. I think that is something that is a very, very critical gap that stands out. And as somebody who's followed this so closely, I think it's very worrying that we are making all these statements about Omicron being mild and vaccine saving lives and all of that without our own data, without having any idea what it has done to us. And remember, and here's why I find this strange. Most of us used Aadhaar for vaccination. Most of us used Aadhaar for testing. Why then can we not track these numbers and give out some lucid narrative about the way the pandemic has panned out in India since the vaccination started?
Right. I think that was briefly addressed, but the numbers were still not given out. There was
no, it was never addressed. Without the numbers, it means nothing.
Right. Right. It is.
Yeah. What was said about linking of databases, we have been hearing for the last 8 months, if I'm not mistaken. First time, sometime last year in July or August, Dr. Bhargava told us in the same setting these exact same words about the databases being integrated. It's high time that we should have some numbers from that integration.
Absolutely right. Thank you again. Thank you so much for joining us today. We did get a lot of insights into how the health communication needs to be improved. What are the challenges that the booster program is facing, and some things for the health authorities to also take from this episode. Once again, we'll be back tomorrow with the virus Decode at 6 p.m. And I hope you will join us again with your questions. We will have a fresh set of experts to answer all of them.